I'm Lee Green. I'm a faculty member and professor at the University of Alberta and the ringleader of the particular project that you're about to see. I'm also a health services researcher, have been for many years, and my particular interest is in primary care systems and primary care transformation, which is what led me to launch into this project. So you'll also see, excuse me, I'll talk for as long as my voice holds out. Unfortunately, I seem to be guest hosting a virus lately, so I don't approve of viruses, by the way. Anyway, June Austin, who's part of the AMA's top program, will be facilitating the discussion. She was also one of the folks who conducted this research, so she may contribute as well. So I'm trying to keep my talk down to, is this thing still working? The sound just changed. Okay. I'm trying to keep my talk down to about 20 minutes, 25 minutes, and then leave lots of time for discussion, because my experience is that when we present this, we tend to set off quite a discussion. All right. So, always have to do my disclosure. None. I don't get in on any of the good graft and corruption. Our team. So this was a partnership between our group, our research team, and the AMA's Toward Optimized Practice program. ENACT, our research team, exists to further community-based, community-oriented primary care research, particularly research in practice and research on practice. So this thing is set up so that I can't actually see my slides from there. Yeah. Terrific. Planning, I guess. Anyway, our purpose is to foster research that helps transform the system. And we are fortunate to be supported by Alberta Innovates, which you see at the bottom of the slide there. They've been supporting the formation and conduct of this team and pre-award development for projects and so forth. So, you probably at this point, everyone in the room knows about the medical home. We haven't put the whole thing on the slide there, but the medical home obviously is the College of Family Physicians of Canada's official policy. It's the official direction of the province of Alberta's primary care strategy, primary health care strategy. And you probably all know that it improves access, it improves patient outcomes, it reduces hospitalizations and emerge visits, it saves money for the system as a whole, helps slow the rise of healthcare expenditures. And that's been demonstrated in many other jurisdictions. We also have successful demonstrations of the medical home transformation in our own province. So we know that it's possible here in Alberta. We know it can be done here. It's not just a thing from somewhere else. And we know that we have, beyond the small number of successful sort of full-scale medical home pilots we also have things like the paneling experience that show us that we can scale at least some elements up to province-wide scale. So we know spread and scale is possible. So basically we can pretty much see the path. We know it can be done here. We know the medical home works. We know we can do spread and scale in Alberta. But despite this, full-scale spread and scale-up of the medical home is still quite a challenge. How do we accomplish that? How do we get these benefits for our patients and save money and so forth? So the challenge. How to get spread and scale was the basic idea behind the studies that I'm going to report. We started from the perspective of diffusion of innovation theory. How many people are familiar with diffusion of innovation? Okay. It's a huge body of literature in hundreds of industries and so forth. Started out actually in agriculture. The origin of it was county extension agents and transforming farming practices in the American Midwest. But it's become an enormous body of literature in the management and organizational sciences studies world. Marketing people live and breathe this stuff. Every industry it's been studied in, from agriculture to electronics, it's how people behave. Anytime you're trying to change a large number of people and the way they work, this is how people behave. So you always have this group way over there, excuse me, way over there on the left, the innovators and early adopters. Those are the keeners. Those are the people who try out new stuff, who like new stuff, jump into it, make it work. And then you've got this main bulk in the middle, the early majority and late majority. The early majority turns out to be key to spread the scale. The early majority is where marketers focus all their time and energy, because reaching the early majority is how you get to the tipping point. Once you get the early majority on side, or at least most of them, most other people, the late majority and so forth, get on board. So once you get to the tipping point, you pretty much win. And that's if you're trying to change the way surgeons work. That's if you're trying to market a new product. It doesn't matter what you're doing. This is pretty much the way people behave. The problem is the valley of death. The valley of death is also called the chasm. You'll see it expressed both ways in the diffusion literature. The valley of death exists because the early majority doesn't think the same way that the keeners do. What appeals to them doesn't appeal to the early majority. What motivates the early adopters and innovators, that's not where the early majority lives. And if you want to get across the valley of death, you have to learn to speak to the early majority. So, how do you learn to do that? We have to understand what's called the mental model of the early majority. You have to understand how they think about what it is you're trying to get them to buy into, whether it's a product or a service or a new way to practice or whatever. That's what we set out to do in this project. So we set out to study how early majority physicians think about and do chronic disease management and approach change and so forth. I'll come back to why we picked on chronic disease management in particular. It is only one of the aspects of the medical home model. However, research elsewhere shows that it is team-based, proactive chronic disease management for the most common major chronic illnesses: heart failure, coronary disease, diabetes, asthma, COPD. It's team-based, organized, proactive management for those conditions that delivers the largest outcome improvement for patients and cost saving for the system. And it does it fairly quickly. The ROI is positive and very positive, like 3 to 1, within 18 months or so. So it makes a great early win. So we decided to focus on that because that's where we can really show that we can make a difference and show it quickly enough to get people on board. So what we focused on was how early majority physicians who started to dabble in this change, how they think about it and how they make it work. The method we chose is called cognitive task analysis. It's a set of organizational science tools, cognitive science tools that are used to understand the thinking, the mental models, and the work, the knowledge work of a team. It may be unfamiliar to folks in this room, but it has a decades-long track record of successfully understanding and improving the work of teams in settings as diverse as aviation, air traffic control, military command, nuclear power plant operation, wildland firefighting, intensive care units. There's a long list of places where this set of methods has been applied to successfully improve team functioning and outcomes in pretty high stakes settings. And it typically has been used in high stakes settings. Historically, it's been quite an expensive thing to undertake. Our actual contribution to the literature is we figured out how to scale it to something you could afford in primary care. But it has quite a long track record. It has a particular value in understanding how experts, teams of people who are good at what they do, think about what they do. It is initially appealing, if you want to see how a group thinks about something, to just go ask them, right? Just go interview them, do focus groups, etc. And that's what people were doing in aviation, and military command and so forth, wildland firefighting, back in the late 1970s. What they discovered was that by applying those methods, which seemed perfectly reasonable, they got very sincere, coherent answers. People told them what they wanted to know, and they went out and they tried to apply it, and it didn't work. And any good social psychologist could have told them why that was going to happen, because we're really lousy at introspecting how we do things. If you ask me how I do what I do as a family doc, I will give you a sincere, coherent narrative. It's just not actually true, is the problem. So the set of methods called cognitive task analysis was developed specifically to overcome that problem. And it has overcome that problem, as shown by its track record in people who play with like nuclear weapons and so forth. It delivers the goods, and we decided that we would undertake to apply it in primary care. We actually led the adaptation of this method to primary care. It has been used in healthcare, in health IT, in intensive care unit, and thoracic surgery and that sort of thing. The anesthesiologists are pretty big on it these days. Surgeons are using it for developing training methods, etc. We adapted it to primary care. What it looks at are these things you see on the screen here as macrocognitive functions. This is our particular packaging. There's different ways to slice and dice the same things, but this is our particular packaging of the knowledge work of a team. So what a team does is figuring out what it does: sense making and learning, making decisions, planning, realizing they need to change things, and replanning, monitoring and detection. How do you know when things are going well? How do you tell when they aren't? Managing the unknown, the unexpected, the irregular. That never happens in primary care, right? And coordinating. People often say communication, but communication is only a part of coordination. Coordination means actually synchronizing the activities of two or more knowledge workers in a group. So, off we went to open the heads of a bunch of doctors and nurses and medical assistants and see what was in there. We did a purposive sample, deliberately focusing on early majority physicians. Now, how do we find those? Well, that's why we worked with the top folks, because they know everybody, and we could pretty quickly zero in on who that looks kind of interesting, but I'm not really an innovator or early adopter kind of people. The people who are interested, intrigued, but not necessarily the keeners, the first ones on their block to try something. So we got hold of a bunch of early majority physicians and their teams. And it's important to understand this was a team process. We didn't want to just understand what the docs thought. We needed to understand what the nurse and the office manager and the medical office assistant and so forth, how the team functioned, how they did their sense making and their planning and replanning and so forth. So we had all of these kinds of folks. We had all of these kinds of folks involved. So off we went to do 42 cognitive task analysis interviews, which, by the way, is an enormous amount of work. What did we find? Well, first, we found that there was a very distinct difference in how the macrocognitive functions of a team were held in early majority practices versus early adopters. We did have a few early adopters in our sample just for comparison purposes. Early adopter teams tend to really function as teams. That is, these macrocognitive functions, there we are, these macrocognitive functions are distributed across all members of the team. The term you'll hear colloquially in the management literature is everyone brings their brain. So you have sense making and replanning being done by everyone in the group. That was very different in the early majority practices. Much more typical pattern in Alberta is that the major macrocognitive functions tend to be held centrally. It tends to be the doctor, or maybe the doctor and the practice manager, who do most of the actual knowledge work. And the other people do tasks as assigned, help the doctor, or maybe the doctor and the practice manager. But it's a very different distribution. If you actually draw it out, and there's software where you can actually diagram this out, what you see in a well-functioning team, in a true teamwork team, is a dense network of interconnection and knowledge transfer and so forth. That diagram looks much sparser in a team that isn't really doing true teamwork. What this makes, actually, is a genuine indication, a way to quantify teamwork. We all say we're teams, but are we really working like teams? And what we found is that, for the most part, not really. For the most part, not really. The early adopter practices, yes, they were. They distributed those macrocognitive functions widely across the teams. But most of the teams needed help learning to do that. We also found that there was a very distinct spectrum of mental models, and I've already slightly alluded to it. The Keeners, the ones who had a very teamwork sort of team, their conceptualization of how they took care of patients with chronic disease issues was, we take care of these patients. But for most practices, for the early majority practices that hadn't, gone whole hog into the medical home model yet, the mental model of practice is, I'm the doctor, I take care of patients, and I hire some people who help me. It's a doctor with helpers model. And there's kind of a spectrum that we found, from the doctor with some helpers to the, I'm the doctor and I take care of these people, but I delegate some of that to the chronic disease management nurse or whatever. I assign other people tasks, to a little further along where they actually delegate some of the decision making and some of the initiative to other team members, until you finally get to the full-fledged team, we take care of patients kind of mental model. It's important to understand what mental model means. That term is not used lightly. It has a very specific definition in cognitive science. Our mental model is how we make sense of the world around us. It sets what we perceive as possible, what we understand, how we think things work. It isn't just a set of beliefs and values. It's dynamic. It's our understanding of what levers you pull to make stuff happen. What would happen if we did that? Why we don't do that. Okay? It is actually a working model, and it's how we set our parameters on what we believe the universe is about. And so what we found was this spectrum of mental models that differs pretty broadly. And of course it ties to that distribution of macrocognitive functions. Now that all sounds very sort of cognitive science-y, but there's good reason for it. And it's because when you actually understand this stuff, then you can actually start to make a dent in it. You can change it. And that's, again, part of the reason for using cognitive task analysis, because it has a track record of helping change things, not just producing academic papers. For the most part, in fact, it hasn't been used as much in academia. It's been used much more in the applied world. The third thing we noticed was a culture in practices that's widespread in Alberta, which we dubbed working alone together. Group practices of 5 physicians that are a group basically in name only. They're not a group, they're 5 soloists. Okay? Each one has a different mental model, each one has a different way of working. Often they don't even share staff, or maybe their staff might cross-cover for each other from time to time, but the docs drive the staff nuts when they cross-cover because they all do things so totally differently. This was much more found in the early majority, or still some of it even in the early adopters. But the key thing is, if you look at a medical home practice, in a medical home that works well and that delivers all those outcome benefits we talked about, people are pretty much on the same page. They're not working alone together. They're singing from the same hymnal. So, how do we scale? Well, we can get across the valley of death and reach the tipping point and get on the easy road from there if we learn to think like the early majority, if we learn to work with the way the early majority thinks. And the way the early majority works, again, very different from early adopters, they need small, incremental, safe steps. They need to see evidence, but evidence alone will not drive their decision making. They need to see that it's accessible, that it can be done, that there's someone there to help them do it. And they need help often to see the big picture. to see the value of the change. A crucial defining difference between the early majority and the early adopters is that early adopters only need the evidence and they'll go to it. The early majority won't swim upstream. They won't work against incentives. If there are perverse incentives in the system, they won't move. And they need some help getting there. They're not as self-propelled as the early adopters. They need some leadership. They need some guidance. So, the reality of pulling off this change is going to sound a little bit familiar from what you may have heard yesterday about practice facilitation. There has been a hope in Alberta, mostly unspoken, sometimes spoken, that if we got some early adopters to pilot some changes and figure out how it worked, then we could economically and easily roll that out to the majority of practices. That is not a realistic hope. Okay. Standards, it works in the back office. It does not work for changing medical practice. The paradigm that has to be used, and again, this is from the org science literature, is not standardization, but mass customization. Okay. And your own experience in your PCNs with paneling and programs like ASAP show exactly what that means. ASAP's ability to build capacity at the PCN level to work with PCNs on a mass customization kind of basis is when we started to get traction with spread for paneling and so forth. And this has been found in all other health systems that have attempted this as well. Okay? The key is, you have, in order to do this, in order to pull off mass customization, you have to have a transformation workforce. Going all the way back to the earliest work with the diffusion of innovation model, it was county extension agents. It was the agricultural extension agent. That was the transformation workforce. Okay? Why do you think pharma hires detail people? It's a transformation workforce. They're trying to transform your practice. They don't want to let you know that, but they are. And that's why there is an international movement for practice facilitation. There's a big international conference held in Washington, D.C. every year. The Agency for Healthcare Research and Quality in the United States has this massive website with a huge trove of materials. There are training programs for practice facilitators in a dozen places that I know of, including in-house in places like Kaiser and the VA. We can learn from other jurisdictions in that regard, but the fact is we already have a really good program like that in Alberta, just not nearly large enough. So what we can do to help practices, the early majority practices, make the jump is provide tools, provide support, and provide guidance. Incentives have to change as well, but we have to think very carefully about incentives. They're dangerous, potentially. There is also a large contingent of people who believe, sometimes implicitly, sometimes openly, that all we have to do is change the incentives, change the payment system, etc., and those practices will change. Well, in Econ 101, they teach you that if you change the incentives, firms change their behavior, right? That's not true. When you take advanced microecon, what you learn is when the incentives change in an industry, a few firms change their behavior and take advantage of the new incentives, but mostly the industry changes by the old firms going out of business and being replaced by new ones that are smarter and more agile and take advantage of the changed incentives. Now, that's fine if you're manufacturing television sets. You don't care that Sylvania went out of business and was replaced by Hitachi, okay? We can't do that with primary care in Alberta, okay? We can't change the system, wait for a bunch of docs to go bankrupt and replace them. We have to help everyone, or at least nearly everyone, make the change successfully. So changing incentives is important to facilitate the change we need, to support it, and most especially to remove the perverse incentives, because early majority people won't swim upstream. But it will not drive the change in and of itself. The practice facilitation role is critical. Now, again, I said, we focused on team-based chronic disease management basically because it's a bright spot. we've got PCNs and practices that are doing it well already that we can learn from. We've got some easy wins that we can get there. It delivers really good results quickly. We also know from a number of studies, including one just published this year, a big systematic review showing that practice facilitation is pretty crucial to achieving that. So what? All right, so first we have to shift our thinking at all levels of the system. We, docs, need to think differently about practice. Policymakers need to think differently about the role of incentives, about the role of support. Decision makers and leaders in AH and AHS need to understand how you really change a large workforce like this and what the different pieces are and how they interact. We need to understand that mass customization is necessary and to invest properly in it, and we need to score that big win so we can show, yes, this works, and people get on board, and policymakers realize, yeah, we did something good, and then we can start getting the other pieces of the medical home brought in as well, and build from there and become the place that other places around the world send people to visit to see how we did such an impressive thing. So the principles that we came out of our work with address the early majority, where they live. Help teams learn to distribute those knowledge work activities and to shift their mental models. They need help doing that. You can't just say, okay, well, start distributing the knowledge work among your team. They'll panic. You have to provide the training and the support and the necessary facilitation so that the docs don't panic at having to let go of some of that, and the staff doesn't panic at having to pick it up. Okay? Practice facilitation is crucial to that. Incentive changes are absolutely necessary, but should be focused on removing barriers and obstructions. And again, zero in on team-based chronic disease management as the first target. So what we're up to now is using what we've learned in cognitive task analysis to train improvement facilitators within the PCNs so that they can do this kind of facilitation work, so that they can help. They have the specific skills necessary to help teams learn to distribute those macrocognitive functions and shift their mental models and really make it work. Okay. So there's another breakout session on change agent frameworks. That's probably worth going to. Hint. All right, questions?